Thank you, Dr. DES JARLAIS. I probably will be standing here so that I don't block anyone. Good morning, everyone, and thank you for coming to our session. I think that the East is no less interesting than the West, so I like the, the title of the panel. So I'm going to talk about the recently completed study funded by NIDA, focusing on reducing methamphetamine use among people with opioid use disorders and on methadone in Vietnam. I'm from Hanoi Medical University in Hanoi, Vietnam. This is my disclosure. I have a test kit donated from Abbott and Roche, but they are not related to the study. Otherwise, most of my work are funded by NIH, and in particular NIDA. So just give you a quick background. This is the expansion. The graph show the expansion of methadone program in Vietnam. Started in 2008. Sorry, this is 2008, and as a pilot, and then starting to expand in 2010. And currently, we have about 48,000, 50,000 patients in more than 300 clinics in all over the country. But there's a lot of challenges. As you could see, that after a period of rising enrollment, there's now quite significant reduction in terms of coverage. But the issue of non-adherence, and especially is affected by polysubstance use, especially methamphetamine, is a major concern. This is not a new issue. Actually, Dr. DES JARLAIS and his colleagues already documented in a publication showing that among the people who not on methadone, this is the people who still injecting drug in Hai Phong, one of the major port city. The use of methamphetamine already started in the early 2000, but especially rising in 2010. Right? So what we are seeing currently is the long-term trend. This is the result that we compare the same almost 600 patients on methadone in Hanoi over 3 years, and we see that the UDS results also increase among our patients. But the challenge is that there's a lack of established treatment system for people with meth use disorders in general in Vietnam. So if they are considered as a social evil, they would be put in the compulsory treatment centers managed by the social affairs sector, which was abolished starting from July 25. And now all of the compulsory centers are under the control by public security. But if they are considered as the patient, then they would be either treated at a psychiatric hospital, which has a very limited experience in terms of the treatment, but mostly focusing on acute psychosis rather than behavioral therapy or other kind of treatment. In the methadone clinic, there's a lot of experience with the OUD treatment and psychosocial support, but there's no experience with the methamphetamine treatment in methadone clinic. And outside of the clinical settings, there's a lack of infrastructure at the community level. So as we know that there's a lot of studies on psychosocial interventions, both either evidence-based or evidence-informed, focusing on stimulants in general and methamphetamine in particular. And these studies, this is the systematic review published in Drug and Alcohol Dependence in 2010-20, already showed that there's a couple of psychosocial interventions like contingency management and cognitive behavioral therapy that have fairly solid evidence and with low risk bias. But other like matrix model, there's a higher risk of bias, and there's almost not a lot of the studies yet have to be conducted on motivational interviewing, as well as the most recently theory-driven SMS for intervention on reducing methamphetamine. So the question for us is that now we have the psychosocial interventions that have been shown effective or have been informed by some evidence. What's the optimal combination of these intervention that could be appropriate for low resource settings like Vietnam, right? So that's the question that triggered us to conduct this study. This is the goal of the study, as I mentioned, to develop and evaluate the optimal combination of different psychosocial intervention to reduce the methamphetamines and improve HIV outcomes among people with EOUD and are currently on methadone in Vietnam. We employ a sequential multiple assignment randomized trial or SMART study design. So this is basically the study design shown in this graph. Right? After the period of screening and motivational interviewing, we randomized participants into two groups. One is the high intensity, we call high intensity intervention, frontline intervention, with 12 weeks of contingency management. And then the other group is a low intensity frontline, which is 6 weeks of contingency management and 6 weeks of group education, right? So the frontline stage is 12 weeks. At the end of the frontline stage, we conducted the assessment, and then we classify participants into response or non-response group to the frontline intervention. For the response group, they were provided with SMS reminders that I will describe in a few minutes. For the non-response group, they were randomized either into a matrix only or matrix plus CM for another 12 weeks, right? And then we conducted the final assessment in week 26, which is another 12 weeks of intervention. So that's basically the design. We went through a substantial period of adaptation, right? So as you know that all of these interventions were created and developed or tested in Western context, and how to bring those interventions into a context like Vietnam, where there's less resources, but especially in terms of human resources, but also other. So we had to use the ADAPT ITT model to conduct the adaptation both in Hanoi and Ho Chi Minh City. And this is some of the activities that I'm not going into detail, and it has been published in an article in 2023. So this is the SMART trial. This is the inclusion criteria. So patient has to score 10 or higher in the ASSIST scale. So for WHO, 4 and higher already considered as a group that need intervention, but we focus on people who score higher than 10 based on the result of the pilot and the adaptation phase. Or they had the positive UDS. They need to have a cell phone that could receive a text message. It doesn't have to be a smartphone. It could be any type of phone that could receive and respond to a text message. And this is the exclusion criteria. And here's the definition of treatment response. We look at the 4 random UDS at the last 2 weeks of each intervention stage, either at week 11 or 12 at the frontline stage, or 24 and 25 at the adaptive stage. And this is the 4 UDS was random. And if the negative, that was considered as responsive, right? This is based on the literature. And here's the measurement. We conducted the UDS at baseline, and then twice weekly throughout 24 weeks of the study intervention. So every week, people were randomly asked for urine sample on a random basis, and then we conducted the UDS screening. We also look at the self-reported med use at the week 13 and the week 36 with assessment week. Here's the primary outcomes, is reduction in med use measured by UDS. Right? And there's also a secondary outcome. I'm not going to present the secondary outcome in this presentation. And here's the analysis. We use the intent to treat analysis. And especially looking at the expected percentage of med negative UDS, or in other words, the probability of having a negative UDS over time. Right? That's the how we look at analyze our outcome. Here's some of the results of the adaptation. For example, in the contingency management, we didn't give the cash because of the political complaint from the staff that we should not give money to the users, right? So we switched to the treatment fees. Everyone in methadone treatment in Vietnam have to contribute certain amount of money. So we converted to treatment fees for them. They could also receive supermarket vouchers, but interestingly, many of them actually wanted to receive household items, right? So for example, fish sauce or other kind of items that they could bring home to their family. Right? And this is the very Eastern kind of significance of the adaptation, that our participants want to show their family that they have improvement that are recognized by the clinics. Right? And this is something that's very interesting for us. We also had to adapt to the reluctance to provide urine regularly, so we had to train the providers on how to address this concern. For the methadone clinic in Vietnam, they only are required to provide urine once a month. Now, if they are involved with the studies, they have to provide twice a week, and that's a big change for them. Similarly, we conducted the adaptation for the group education in terms of the timing of education, in terms of the group and individual session, but also the schedule of the providers. And here's I show you some of the household items that were valued by our participants. And they, for example, this is the coffee, instant made coffee that could bring home. This is some of the hygiene products that they could bring home to their family, right? And here's the theory-driven SMS. On the left-hand side is the one-way SMS, text message during the weekday. Every day they would receive 5 text messages like this in the morning, mid-morning, and during the daytime, but they were not able to respond to the messages, right? And all of these messages was theory-driven. What I mean is that we use theory like health behavior and belief, health HBM, to design the text messages to emphasize the need for abstinence, the need for relapse prevention, and so on. And during the weekend, we texted them only 2 times each day, and they were able to respond to just to indicate 1, 2, or 3, right? So that's how they respond to our text message. So let me show you the result of the trial phase. This is we screened almost 7,500 methadone patients in 15 clinics in Ho Chi Minh and Hanoi, and the total number of enrolled was 667, and 2 of them, after the enrollment, they declined to participate in the study. Right? They changed their mind. So out of we had a very high retention. So the overall retention was 90% at the end of the whole entire trial. And this is the things that we are very excited about. And here's the characteristic of the participant at the baseline when they were randomized into at the frontline intervention stage, either low intensity or high intensity. So we see that there's no significant difference either in terms of age, in terms of ATHS score, or in terms of the méthamphétamine EDS positivity, as well as the HIV negative, and so on. So let me go to the primary outcome. And here's the several primary outcome. We look at the difference in terms of 2 groups, the frontline versus, the high intensity versus the low intensity. And as I mentioned earlier, that this is the expected percentage of methamphetamine negative urine over time. Right? So as you could see that in the blue line here, there's a significant reduction at the starting of the study to the point of significant increase, for the high intensity group. And similarly for the low intensity group, we also saw a significant improvement in terms of the expected urine negative. Interestingly, at the end of the study, the difference between the two groups was not statistically significant. Right? But when we look at the week 12, that was when the significance was the most pronounced, 8.3% between the high intensity and the low intensity. So it shows that the frontline intervention really worked, and it's something that we want to emphasize. And here's also once they pass the intervention, frontline intervention, now they are in the adaptive intervention stage. You could see that for the matrix group only, between the week 14 and week 25, there was no significant difference in terms of the expected urine negative. But for the group with CM plus CM, there's an improvement in terms of the urine negative, right? Expected urine negative, and the difference is statistically significant. For the SMS group, so remember that people who enrolled in SMS group was the one that responded well to the frontline intervention stage. So now, if you look at the low intensity, there was a reduction in terms of urine negative, right? So from 92% to about 89%, the difference was significant, but still about almost 90% of participants were urine negative, expected urine negative probability at the end of the trial. And that's quite encouraging for us, that it shows that the SMS as the maintenance intervention actually worked. So I just want to show the impacts on heroin use. Right? So as I mentioned, that the participant not only using methamphetamine, but also using co-used heroin as well. And here's the similar analysis for heroin use. So it shows that comparing the frontline intervention, again, it's most significant difference is at the end of the frontline stage. But by the time at the end of the study, there was no difference between the two groups. And similarly for the adaptive intervention. And for the SMS group, they maintained a fairly high level of heroin negative. So which shows that the intervention worked both in reducing methamphetamine use, but also in reducing heroin use among our participants. So here's some of the conclusion. I think that the co-use of meth and heroin and other substances among people with OUD, especially among people on treatment, is an issue that we need to address. And our studies show that the feasibility to integrate in culturally adapted social intervention into MODD treatment in resource-constrained settings. And this is not only for Vietnam, but we're also thinking about other settings in the world. So we are talking about the frontline stage, the adaptive stage, the intervention. Our study has a limitation in terms of, this is conducted in urban settings in Vietnam. All of the clinics were very well equipped in terms of staffing, in terms of the assessment to clinic by the patient. And especially this in the e-treatment population. So for our next step, we have just submitted a new grant that we will conduct an implementation science study, but in rural settings, and combining both the enhanced support for providers, but also a telehealth kind of component into the intervention. So I'd like to thank the study team, all of the study team, especially also the participant. And this is our advisory board. You could see that Professor Shoptaw, Professor DES JARLAIS, Dr. Gavin Bart, and Professor Rosen, among many others. Thank you.
Do you want to take a question? John, do you want to take a few questions? Okay, it was a very thorough presentation, so if we do not have questions, The next speaker is Cécile Denis from Philadelphia, but also speaking about Vietnam, in particular preferences for different types of mood.
Okay. Hi, everyone. That works, yeah. Good morning. So I'm going to present some data on MOUD choice, medication for opioid use disorder choice. So before, like most of the studies that are interested in factors associated with MOUD are focusing on factors associated with retention in medication for opioid use disorder, but very few studies actually are looking into factors in MOUD preference and the role of MOUD preference in this equation. So there are several factors to consider when a participant have to give a choice of MOUD. So there are like 3 MOUD approved: methadone, buprenorphine, or extension-release naltrexone. Several factors to consider, as I said. So we have the systematic factors. It's basically the availability of MOUD. Where you live, do you have access to this kind of MOUD? Do you have access to provider? Do you have a healthcare system that support this MOUD? There are also some other social factors, like for the person. They have access to the transportation. Do I have access to the care? Do you have access to the clinic? Do I have like economic factors influence? Can I offer that? I mean, like if you need an insurance, do I have an insurance that covers this type of treatment? There are also demographic, social supports, your substance use history, what kind of substance I use, what can I do, and the criminal justice involvement. In some area in the world, some involvement in some justice system, you don't have any choice actually of the type of MOUD. And then there are like also some medical factors. There is medical clinical requirement, like for instance, if I am a woman and I'm pregnant, I'm limited in the type of treatment I can have. There are co-occurring medical conditions or co-occurring mental health conditions that can contraindicate some MOUD. And then finally, all the substance use history and treatment history. So consider all these factors. We wanted to look into I would love to tell you that was an ongoing study because it was supposed to be an ongoing study, but unfortunately the US government, federal current government, decided to prematurely stop this study because international, so no funds for that. So this study has been early termination, so we're trying to do whatever you can with the data we have collected so far. So from this study, we're looking at the MOUD preference in participants who are randomized in methadone, buprenorphine, or extended-release naltrexone in Vietnam. So basically, the study design, and this study was not like designed to really study MOUD preference, but I'm going to get to that later. We are using this study to approach that. So the hanoï study, it's how it's called, enroll people who have opioid use disorder, not in treatment, and HIV in treatment with antiretroviral therapy or not, but willing to start MOUD and willing to start ART if they are not already in MRT. And the people are randomized, the participants are randomized, in methadone, buprenorphine, or extended-release naltrexone. The overall objective of the hanoï study was to measure the effect of the activation of the mu-opioid receptor in immunoreconstitution in people with HIV and MOUD. So I'm going to focus only on this, what's happened in this induction, because also it's a randomized controlled trial where people are randomized in these 3 groups. The protocol allows for switching at the time of the randomization, and up to 30 days, they could switch treatment if they are not feeling like continue the treatment they were randomly assigned. So we are going to focus only on this part, and Livio in the next presentation will give you more detailed overview on the rest of the outcome on this study. So here I'm going to just examine, looking at the frequency of switching, the MOUD preference, and then the associated factor with this MOUD preference and switching. So basic characteristic, we enrolled 78 participants, mostly were male, about like 42 years old, and as a substance, they were using mostly heroin, that is typical in Vietnam. The main opioids used is still heroin, as far as we know. And there are like about a quarter of them were also using methamphetamine and reporting using methamphetamine. Tobacco is pretty prevalent with almost everybody was smoking. So using heroin for about 12 years, and all of them have previous treatment for opioid use disorder. If you look at that, the most common is the O6 center. O6 center, if you're not familiar with Vietnam, is a mandatory detoxification. So this is a criminal decision, justice by using drugs and sending for a mandatory detoxification for 18 to 24 months. So almost all of our participants have experienced either like going to the O6 center, either detoxification were voluntary, they went like voluntarily in detox center. So the switch, the randomization, on the top in this, on the top in this graph is like the arm assignment per randomization procedure, and this is where the switch, after the switch. So as you can see, like allowing the switching at the randomization doesn't like significantly imbalance the number of each arm. If we look in more details, who switch and not switch here, in this table, the section highlighted in green is actually those assigned in this in the treatment and decide to stay in the treatment. So we are like about 50, it's actually 50-50. 50% decide to stay in the randomized treatment, 50% decide to switch to another treatment. And we didn't find any association with switching to a particular treatment or from a particular treatment to another treatment. It was pretty balanced for the three treatments and across the three groups. When we look into details of the reason for switching, and I have to say that most of the switch occur before the, just at the time of randomization. They were randomized, and the date of randomization, at the time of randomization, they said, no, I want to switch. So they never really experienced another treatment. When they wanted to switch, it was pretty much like directly at the time. So the main, whatever treatment, methadone, buprenorphine, or extended release naltrexone, the main reason was just, I prefer another treatment without like clearly details of why they want, they just didn't want that assigned treatment. For methadone, and for methadone only, we have like also previous experience, negative experience. The only available treatment in Vietnam, beside the detoxification, is methadone. There are no other available treatments. So some have negative experience with methadone and assigned to methadone and say like, no, I don't want to get methadone. The buprenorphine arm, we had like a fear of withdrawal to stay like at least 24 hours without using before getting the first dose of buprenorphine was too stressful for some of the participants, and they decide to take another treatment because of that. And for the extended release naltrexone, we have, they had to go for 1 week inpatient detoxification before like having the first injection of extended release naltrexone, and some were unable to go for away from their family or work for 1 week to get the first injection. Otherwise, it's like mostly like logistic things, living too far from the clinic, missing ID. So if you miss an ID, you cannot get access to any treatment in Vietnam. So there was like some more anecdotal reason for switching. When we look at the baseline characteristic of data that we have collected at baseline, we didn't find any association about predicting who switched or not switched. So everybody was pretty balanced in the three groups of switching and not switching. So we had decided to look at like either like switching and not switching have an impact in retention into treatment. We look at the 26-week follow-up. So first, regardless of that, we have a very high attrition in this study. And if you look like, we have like, at 26 week, we have like a little over, like just a little over half of them who stay at least 26 weeks in treatment. For that, we didn't find any association with the arm. Methadone, buprenorphine, or extended release naltrexone was about the same, no difference in retention. The reason for termination, it's actually we have to encounter, at the time of the recruitment and the study was ongoing, there are a huge policy that happened in Ho Chi Minh where they have a very, very strong police presence and police arrest and send people to O6 center. And we have like half of those who didn't complete the study has been arrested and sent to mandatory detox center at that time. So that was the main reason for termination, was like taken by the police, arrested, and for most of the time, they were positive for methamphetamine use, and so getting arrested and sent to detoxification. Some are like moved far from the clinic. We have like only 5 who are really true lost follow-up. We don't know where they ended, like no contact with them. Some decided to stop the treatment and deciding to stop the study. Also, these 4 who stopped the study continued the treatment. They were not assigned in, they were assigned in methadone and decided to continue methadone, but not participate in the study anymore. So if you look at the COGS model here on this graph, the blue line is the people who switched treatment, and the red line is those who didn't switch. We didn't find any significant difference of who switch or not switch treatment at 26 week. So conclusion, so this was like an opportunity because there is like really no study who have a availability to randomize and really control these 3 groups of MOUD. So that gives us an opportunity to better understand or at least examine some variables that could have an impact on the treatment of choice and the treatment on the retention. We didn't find any association between any baseline characteristic and the likelihood to choose one treatment over another. We didn't find either any association between those who switch and not switch and the retention at 26 weeks, but like our sample was rather small, so we cannot really conclude really on that. But I want to highlight the most important part for us was the retention in treatment that were affected not by people really characteristic, but more like a systemic and social factor associated. So that is like the most important point for this study. And this is all the people involved in this study, the hanoï study. Takes a village. So with our institute, the University of Pennsylvania, we were in partnership with IMEA in Paris, the Institut Pasteur, and BCA with Dr. Jean-Pierre Delouet, also involved in this study. And this is it. And if you have any questions. question, yeah.
Thank you, Cecilia. This is the very, very important study for Vietnam as we pondering about what next in terms of the OUD treatment. I was just wondering, it looks to me like there's more people on the naltrexone injectable who want to switch. Is that right? And also many of them just say that they prefer other treatment. Is there more specific information on why they prefer other treatment? Thank you.
So we don't have more details on why they say they prefer other treatments. Some report negative experience, previous experience, some more logistic barrier, but most of them say I want to have another treatment without really giving really more details of why they don't. It's just personal choice. If you look at the number, but same the sample is really small, and at the absolute number, yes, you're right, there were more those who were assigned an naltrexone, decide to switch. The main reason was they could not go for 1 week detox, not so much by the product itself or the medication itself. It was just completing this 1 week, but that was not reaching any statistical difference with the sample size.
Thank you. And in several of the studies in the United States where there's been randomization, generally it's buprenorphine and methadone, not a naltrexone component. Recruitment and randomization has been extremely challenging because patients do not even want to be randomized. They already know which medication. So when you have your initial diagram of the study, you're including the people who've already expressed willingness for randomization, and then they switch after randomization. Do you have, further on the left of the curve, the information about people approached about this study who didn't want to participate because they did not want randomization, and did they express the reason why, because they had a specific medication they wanted to be on?
So we have screened 5 more, 83, and 78 randomized. The 5, they decide to not join the study, but I don't know specifically if it was because they didn't want to be randomized or taking the risk of being in a group that they don't want. That I don't have the details, but I know that we have 5 who are screened and not randomized. But no more details. That could be other things also, or not wanted to take at all MOUD. But it was clear at the time that they had the possibility to switch. This was really explained to them at the time of explaining the study, so they knew they can. We have 1 letter that switch, and then after 1 month of switching, decide to again switch. So that is not a law that has been discontinued from the study. It's happened, we have only 1 occurrence that, of person we wanted to switch twice. Okay. So I'm going to introduce our next speaker. So is Dr. Livio AZZONI from the Whistler Institute in Philadelphia, and he's going to continue presenting some data about the same AMOE study.
Some more of the same. But this is a little bit different, so Cécile already introduced the study. I will go quickly through that. But this is more about the biological, not necessarily the endpoint, because we haven't finished we actually just started the longitudinal analysis, but these are more baseline information. So I'm going to talk a little bit, but very quickly, about the study, finding disclosure of background. We'll focus a little bit more on the background. Study design has been already covered. And some of the baseline analysis that we did, again, the mostly functional parameters and immunology parameters. And you can see from the background why we did that. And then we'll just conclude the presentation with the acknowledgements. So Cécile already introduced the sites that collaborated here. The study was based in Ho Chi Minh City in Vietnam, in collaboration with Institut Pasteur and BISIA here at IMEA in France, and Pasteur Institute in Ho Chi Minh City, University of Pennsylvania, and our Western Institute. And the IRBs were both in Ho Chi Minh City, the Pasteur Institute IRB, and the University of Pennsylvania IRB covering the study. Funding was entirely provided by NIDA, the National Institute of Health, and I have no personal conflict of interest to disclose. So the background for the study, essentially, we know that chronic opioid use lead to chronic immune activation and immune suppression. And immune suppression is actually a result of the chronic immune activation for the most part, linked to exhaustion of the immune cells. There are several reasons why this happens, and it's not really fully studied, but one of the main reasons is the direct activation of immune effectors, which essentially the immune cells from monocytes and macrophages, through the opioid receptors and the TLR4, which is a toll-like receptor for the recognizing bacterial products. And those receptors together, when they're stimulated, they lead to the activation of the cells chronically and eventually to exhaustion of those cells so that they won't react to new pathogens. There's also glial cell activation. Everybody knows that. You know, this is in the brain, and this is one of the reasons that there's damage in the brain related to opioid use. There's also involvement of the hypothalamic pituitary adrenal axis for the cortisol and catecholamines that are stimulated as a result of the use of chronic opioid use. And then, and this is probably the most important and the least studied, is the alteration of the gut microbiome, which presents with lower diversity and importantly also lower bile acid metabolizing species, so that the bile acids that are produced by the liver are not metabolized to the normal products. And together with all this, there is also, of course, the phenomenon of constipation that leads, it's related to the decreased motility of the gut that leads to all of this alteration in the gut microbiome. And it's very popular now. The microbiome is regulating the entire immune system through bacterial products and interaction of bacterial byproducts that can penetrate through the gut barrier. In people with HIV, there is an extra problem. So first of all, HIV itself induces immune activation and immune suppression all the way to AIDS when, you know, the CD4 goes below 200. But there's also an impaired immune reconstitution when people are treated, but most importantly, the disease is mostly local. Contrary to popular belief, is mostly localized in the gut, and the gut immune system is the one that has the brunt of the attack of the HIV, particularly in the acute phases. It never recovers completely. And so there's a residual permeabilization of the gut barrier, essentially, that allows bacterial products to be transported into the system and be recognized by immune effectors leading to chronic activation. When HIV is associated with polysubstance use, then it could, the two effects of, you know, continuous immune activation can overlap and act synergistically to induce even more immune suppression. And most importantly, the recovery on ART might be impaired when there is also opioid use. Another thing to remember is that MOUDs have different functions. So some MOUDs, buprenorphine and methadone, are agonists of the mu receptor, and so it's expected that when you use these MOUDs, you would have, on the immune system, you would have similar effects as when you're using opioids. So, because they are opioids, essentially. So the constipation and the microbial translocation and so on should be present in people that use MOUDs. And whereas using naltrexone, which blocks the mu receptor, should reverse those effects. We already demonstrated in another earlier study that the soluble CD14, which is a marker of immune activation and microbial translocation, is actually increasing in individuals that use methadone and potentially buprenorphine, indicating that this hypothesis is quite likely, and using MOUDs that are agonists to the mu receptor actually could lead to continuous immune activation and immune suppression. So the hypothesis for the study is that if we have people with HIV that are starting treatment or at the beginning stages of the treatment, so they are still high activation, and they have opioid use disorder and also initiating treatment with partial or full mu receptor active agonist, then in my experience, a limited or delayed immune reconstitution as compared to people that use naltrexone. Because again, there would be a synergism between the MOUD and the residual immune activation of that is left after initiating ARDS. So the limited replication of HIV and the presence of HIV in reservoir induces microbiosis, translocation, and the MOR contributes to that. So if I block it with naltrexone, I would have probably a better immune recovery, and if I use methadone buprenorphine, then the hypothesis was that immune recovery would be worse. So that's the whole premise for the study, and so Cécile already showed the whole graph, so I'm not going to spend a lot of time here other than indicating that we're going to look at the beginning of the study, so people as they were coming into the study. And these are characteristics, again, Cécile already reported this, but this, I added a few things here. So things such as reported age use by sex, similar, so in their 20s, approximately 11 to 12 years of opioid use in average, using opioids every day. And we did point of care urine drug screening at the beginning and then continues doing the screening through the study. And obviously everybody was positive for opioids because that was one of the entry criteria. But as Cécile already mentioned, a number of individuals were also positive for methamphetamine and a smattering only positive for MDMA or THC, marijuana. You can see here that the CD4 count at the beginning of the study was quite low. It's not in the AIDS area yet, but it's in an area in which you will start treatment even according to the old guidelines of 350. Log viral load, a lot of people were already suppressed, so this is a bit, it's not really indicative, but the viral load was 2.7 to between 2.5 and 3 logs essentially. For people that were viremic, of course. And then the people that already were taking ARVs at baseline, it was 11 of 13 women and 49 of 59 men were already on treatment. Not necessarily suppressed yet, but already receiving treatment. This is just a representation of the screening, the urine drug screening at baseline. So again, about 32% already using methamphetamine. These are the population that we analyzed. It's a little bit limited. We were doing all the analysis that I'm presenting now on site at the Pasteur Institute in Ho Chi Minh City. And so we could only use a dual laser fax machine. And so we looked at different population of T cells, and I'm not going to go into many details, but just to quickly summarize the functions and the markers. So the markers, the CD4 for T cells, for the helper cells that help the activation of B cells, CD8, and so on. So basically mastermind the immune activation, and the one that specifically target by HIV and depleted when HIV is replicating. For CD8 positive T cells, those are the cells that are cytotoxic, so the cells are actually protected by killing cells that are infected by the viruses. And the marker, again, is CD8 for all of these cells. These markers, HLA-DR, CD38, CD69, are all markers of activation that would indicate that these cells are actually active and recognizing something with the potential of being exhausted eventually. For the monocytes, which is the antigen-specific responses, we have three main populations of classical, intermediate, and non-classical based on these markers. And basically, the classical and intermediate are pro-inflammatory or can become pro-inflammatory. So if they are increased or activated, there's a good possibility that there's increased inflammation and activation going on. They also express PD-L1, which is a marker, essentially is a trigger that can induce T cells to become exhausted and stop responding. So when PD-L1 is expressed in the monocytes, it's likely that T cells are not having a full functional response. So what happened? First, we look at the suppression of the HIV replication with ART and see how that would work in these particular patients that had both MOUD opioid use disorder and HIV. And the response is normal, so the people that are already receiving baseline ARVs, they have lower viral log. Again, they're not necessarily all suppressed, but it's definitely lower than the other group. CD4 are higher in percent and in numbers, and the CD8% conversely are lower because that's just the relative percentage of the cells. If you look at baseline viremia, so these are people that we actually measure the virus replication. People that don't have any viral replication, again, have low CD8, high CD4, and no replication for the virus, so no viral load. And the people that instead had a viral load, a baseline viral load, you can see that the log here is around between 3 and 4, so between 1,000 and 10,000 copies per ml, going all the way up to 1 million copies, depending on where they were in their journey. But these were all the viremic individuals. Again, most of the viremic individuals were the people that were not on ARV yet. And immune activation related to that is represented here. So people that were receiving baseline ARV had lower activation in general. And you can see by the expression of CD38, on HLA-DR, and all those markers of activation that I already presented before, those are all lower in people that were suppressed, that were receiving antiretroviral therapy. These for T cells, for monocytes, classical monocytes were increased. Again, there's a pro-inflammatory, so we don't really know what that means exactly. But most importantly, the expression of marker of activation on those monocytes were lower when people were receiving ARV. So overall, virus suppression resulted in decreased activation of adaptive and innate immune effectors and increased monocyte subset, which are all positive signs. So these patients are responding like patients that don't have opioid use disorder. So this is the response you would expect in any population of HIV when you start treatment. Now, what was the effect of the length of use of heroin on immune activation? This was a little surprising. If you see, this is just a linear model in which we tested multiple factors to see, if they were independently affecting these various activation parameters. And you see that there's a lot of activation. I didn't put in this table the one in which there was no effect, but when the effect had a p below 0.05 and adjusted, you can see that a lot of activation markers are affected by the length of heroin intake, but unexpectedly, this is a negative effect for all of them. So the length of heroin use is actually inversely proportional to the activation. The longer people use heroin, the less activation you notice. Again, this might be related simply to the fact that the cells have been energized at this point, and so they're not active anymore. We don't know that yet, because we didn't look at other markers on these cells. The effects, as you expect, the viral load has a positive effect on the activation, so the higher the viral load, the higher the activation, and these two effects were independent. So again, summarize, the length of heroin use, a negative effect on immune activation that is independent of viremia. Most of our patients had, all of our patients I would say, but most of our patients had HIV co-infection but we formally tested only 53% of the patients, because at the beginning we weren't testing, and we started testing after the study had already started. And some people were not, they already had been tested, but we did not have the results. For the 53% that we tested, 74 were actually had detectable viral load for HCV, so they were not suppressed, and we put them in treatment for the HCV. And we did not notice any effect on innate immune or adaptive immune parameter except this. So people with high viral load had higher classical monocytes. Again, they're normally a pro-inflammatory, and higher neutrophils that can also be pro-inflammatories. All the other parameters were the same. So this is just something to keep in the back of our head. Some of the effects that we see are not only exclusively due to viral load of HIV and length of heroin use or anything like that, but could potentially be also associated with the HCV co-infection, so hepatitis. So in summary here, the population, we had increased CD4 when they start treatment, reduced T cell activation, and reduced monocyte activation, as expected. The duration of heroin use has a negative effect on the activation parameter, and then HCV co-infection results in an increase in innate immune effector, potentially increasing activation. As I said, there were approximately 30% individuals that were using methamphetamine, so we wanted to see what the effect of the use of methamphetamine, if any, was on these parameters. And we looked at, these are just behavioral variables. We looked at a bunch of different behavioral variables. We only saw an effect on these variables, the earning and the days worked. So we were looking at how many days these people worked per month and what the earning were, and this is in million dongs, I believe. And so people that were using methamphetamine, so they were tested positive for methamphetamine at the screening, worked fewer days, almost a half of the days worked by the other population that was only using heroin. And their earnings were also approximately a half or even less. So there was definitely a positive effect on both, which is interesting. It doesn't tell us much about the activation, so we'll get to that. So the effect of methamphetamine on monocyte subsets is the first one that we looked at. So we looked at all the monocyte subsets, and we saw a positive effect on one of the subsets, which is the classical monocyte subset and the expression of HLA-DR. And you can see that, again, this is a linear model, so the negative effect of log viral load, so the viral load as it increases, you have less of the population that is classical monocytes, which, again, they're supporters of immunity. So if you deplete them, you would potentially have worse responses to pathogens. And this is expected, it's been described already, but when you look at the effect of methamphetamine, so people that were negative for UDS screening at baseline had a higher line here. So they mean that they started higher and they end up higher as well. So this is a positive effect and a negative effect for the methamphetamine use. So basically, in summary here, it means that methamphetamine had a negative effect on the activation of these classical monocytes, and this effect was independent of viremia. I just wanted to point out here that the individuals that tested positive for methamphetamine reported slightly less frequent heroin use. It wasn't significant, but it was slightly, I'm sorry, it was significant, it was pretty small, so 25 days a month instead of 30, essentially. How accurate that is, we don't know yet. So, and it's difficult to determine, and it wasn't a large difference, but it's possible that on some days, people either didn't report using or didn't use heroin, but used only methamphetamine. It's quite unlikely, but. Now, these again are the effects of a positive or negative effect, positive or negative test, UDS test for methamphetamine. Now we look at different viremic groups, so people that were viremic at baseline or people that were suppressed at baseline. So people that were suppressed are most likely to be on treatment for ARTs. People that are not suppressed are less likely, so they're probably either just started or were not receiving ARTs. So when you look at the non-viremic people, so people that were suppressed, you can see that individuals that were using methamphetamine had higher PD-L1 expressed on monocytes, both intermediate, both by percentage and by intensity. So they had more PD-L1. If you remember, I mentioned that PD-L1 is a signal that tells T cells to stop responding, a signal of exhaustion of T cells. So in a situation in which the viremia is suppressed and you expect everything to go back to almost normal, people that had used methamphetamine, they're using methamphetamine, are not going back to normal, and they keep signaling T cells to not respond. So they have exhaustion of those T cells. And this is mediated by the expression of PD-L1 on monocytes. For people that instead are viremic, so the virus is still reproducing, you can see that the non-classical monocytes are higher in individuals with methamphetamine. So that we don't know exactly what this imbalance means, but there is an imbalance also for people that are viremic, meaning that the effect of methamphetamine supersedes the effect of the virus. So it's even greater effect than the virus alone. So in terms of toxicology, in people with HIV and active opioid use, the methamphetamine co-use is associated with reduced activation of classical monocytes. And again, this effect is independent of viral load. Increased classical and non-classical monocytes, and increased expression of negative checkpoint immune modulator PD-L1 on monocytes, signaling that this might lead to a lower activation and exhaustion of T cells. And this is just a preview that I want to show. So what happened to people that use methamphetamine at the beginning? Are they more likely or less likely to stay on the study and to keep using? Again, this is just a preview, so it's very unofficial. We didn't do the statistical analysis yet, so I can't tell you that this is significant or not. But I thought it's a good visual for what happened during the study. So what I'm showing here at the beginning is the positivity for opiates only, in this case, specifically heroin, in red, and in purple are the people that were positive for opiates and methamphetamine. So this is the very beginning here. Positivity for methamphetamine alone is in blue, and negativity is green. So that means in green that all the urine drug test was negative. And in gray is just a progression through the study to the last UDS, so the last urine test. And these are the three arms. This is the as treated, so that these are not the randomization arm, but the arm that the patient chose to be in, so their preferred treatment. And if you look at buprenorphine and naltrexone, you see a lot of drop-off in both groups. But what you also see is that the buprenorphine has a lot of positivity throughout. So people on buprenorphine kept using opiates or opiates and methamphetamine, or some people methamphetamine alone. Whereas people on naltrexone, there were some use at the beginning, but those people dropped off, and then people that remain on treatment stopped using, which we think is very interesting. But importantly also is that methadone had a much lower drop-off, so people stayed on treatment with methadone, but they were also kept using it, both methamphetamine and opioids throughout the treatment. So again, this is just an official preview. We will do the analysis and see if this is actually a significant difference between the arms or not, but it seems like there are obviously differences between the treatments that could potentially have implication for both retention and continuous use or abstinence from use of the substances in general, both opioids and methamphetamine. Conclusion, so the results indicate that opioid use and viral replication independently contribute to T cell activation. Methamphetamine co-use is associated with alteration of the immune effectors despite the viral suppression. And this suggests that stimulants may sustain immune suppression even after the virus is suppressed, so even after HIV suppression. And we're planning further longitudinal studies, of course, or the primary endpoint. And the primary endpoint, just to remind everyone, that's the soluble CD14 and the activation over time for the entire duration of the study. And then hopefully we'll be able to characterize the substance use during treatment a little more in depth, and also characterize the immunological and metabolic signatures that accompany these treatments over time. This is just acknowledgements. You've already seen most of the group from Cécile's presentation. So I just wanted to thank again all the participants and everybody in the team that was super dedicated. And we had a lot of obstacles, including COVID-19 and changes in policies and all sorts of things. It's amazing that we even recruited the people that we did. So it's impressive. These are all the sides of the study and all the team members that participated. And with this, I'm concluding. I'll take any questions. Thank you.
Livio, you have one question, I think.
Great presentation. It's nice to see the immune data in particular. I'm wondering how you reconcile some of the elevations in soluble CD14 that we see as a function of methamphetamine use with the immune exhaustion markers that you're seeing. Is that just the time course of this, that there's an activation followed by an exhaustion? Yeah.
Yeah, hopefully by combining the PD-L1 expression and, if you go more in details, we can look at the PD-L1 receptor on T cells and so on. We did preserve cells and plasma from all the individuals in the study. Some of that got lost due to custom issues that, samples were lost in the heat in the summer. But we should have enough material to actually look at, characterize the cells a little more in depth, and certainly to do more metabolic assessments that would probably indicate whether this is an exhaustion issue. So you would have activation, and then the prolonged activation might result in. Fortunately, for people that were already treated, it's a little bit difficult because there's a very rapid change at the beginning of the treatment and then a stabilization. So we might need to look at those populations separately, people that were still viremic and people that were suppressed. Yeah.
Oh, you have another question?
Oh, another question, sorry. Too fast.
Thanks, Livio. So from the data on the different medications, it seems with naltrexone, there's a higher rate of abstinence, but the dropout is very disappointing. So how does this translate to recommendations for patients if they're choosing treatment?
That is $1 million question that we might have been able to answer if we had 75 patients in each arm, which we don't have. So at this point, it's still anecdotal. How does it translate? I think it's the goal, it depends on the goal of treatment, right? So if your goal is abstinence, then naltrexone is king, right? But you might lose a lot of patients that might not make it there. If your goal is harm reduction, and then I think probably you would choose the method that keep people on treatment. So méthadone would be the one that you would choose in that case, even though you know that people would continue using. In that particular setting, people that continue using could be arrested and lost to treatment. So, again, there's a lot of factors that are not necessarily medical decision that might alter your choice.
Any other question? No? Okay, so we are going to introduce the next and last speaker of the session is Dr. DES JARLAIS from New York, and he is going to, we are leaving Vietnam and going to Estonia to looking at the epidemic of méthadone.
Thank you, Cécile. Estonia is a small country of about 1.3 million people. It borders the Baltic Sea, to the north and Russia to its east. It is a potentially geopolitical issue because Estonia is part of NATO, and a Russian attack on NATO would be considered an attack on all NATO countries. And we've already seen Russian jets doing incursions into Estonian airspace. From a drug use perspective, it is also extremely interesting because it has had the rapid evolution in drugs. During the Soviet Union days, when it was part of the Soviet Union, the primary opiate was poppy straw. It then went through heroin, it then went through fentanyl as the main opioid, and now it's seeing the nitazines as the primary opioid. Nitazines are a class of synthetic opioids, fairly diverse and very potent. And I'd like to acknowledge a large number of collaborators on this study, particularly Katri Abelolo, who has done the most work on it, Anneli Uskala, who has been the senior author from Estonia on our Estonian work, and then a large group of civil servants from Estonia who have pulled together the administrative data. Okay, the support for this study was primarily from the government of Estonia, the National Institute of Health Development, and the Estonian Forensic Institute. The University of Tartu and New York University also contributed time as some of the authors, and none of us have any conflicts of interest for this study. Estonia had a fentanyl epidemic from about 2002 to 2017. During this time, fentanyl was creating an extremely high fatal overdose rate, and Estonia really led the world in terms of per capita fatal drug overdoses. Then in 2017, the criminal network that was providing the fentanyl was disrupted. There was one major lab that was providing most of the fentanyl. The police found that lab and shut it down. So there was a real drought of fentanyl after 2017. But then starting in 2019, nitazines started showing up in the market in Estonia and also in Latvia. And the nitazines, like fentanyl, have led to very high overdose fatality in Estonia. The purpose of this presentation is to give a country overview of what happens in a nitazine epidemic, including prevalence, usage patterns, and health consequences of nitazine use. We basically did a country case study using administrative data, surveillance, research data from administrative sources, and we did qualitative structured interviews with individuals in 2 cities, in Tallinn, the capital, and Narva, a city on the eastern section of Estonia, very close to the Russian border. And the qualitative interviews, including people used nitazines, emergency personnel, and drug treatment personnel. The first emergence of nitazines in Estonia was in October of 2019, when they were detected in urine samples and small seizures. Then from 2020 through 2021, mostly of isonitazine, then various single nitazine compounds found in 22 to 23 that included various adulterants, including methadone, cocaine, amphetamine, and fentanyl. And then in 2024, there was mixtures of various nitazines, including metonitazine and protonitazine. So that this is really a collection of synthetic opioids coming into the country rather than any one particular nitazine. This shows a timeline from 2015 through 2024 of what was happening in the country. The top line is HIV cases, which have been going down very consistently over time in Estonia. Then the second line is the drug-related deaths. And you can see during the mid-20-teens, a high level that was due to fentanyl. Then fentanyl lab was shut down. Drug overdose fell very dramatically down to very low levels. And then when the nitazines came in, drug fatalities increased greatly. The number of syringes exchanged has stayed relatively constant at about 2 million. There's been a dramatic increase in naloxone distribution to try to counter this recent increase in fatal overdoses. This line shows the fentanyl seizures, which were very high around 2017 to 2019, and now have gone down to extremely low levels. And then the nitazine seizures starting in 2019 and jumping around with various types of nitazine in the 2020s. Okay. This shows the demographic characteristics of the drug-related deaths, and you can see the increase in drug overdose fatalities from 27 in 2019 up to 113 and 100. The rate per 100,000 population is very high for any country in Europe. Fatal overdoses involving fentanyl have gone down to very, very close to zero. So that the fentanyl issue has really been pretty much resolved, but the nitazines have increased very dramatically. Okay. We have done a number of qualitative interviews. Users of nitazines describe the effects as stronger, faster, and sharper, and more short-lived than fentanyl. That it's a very strong drug effect. It takes effect very quickly, but doesn't last very long. And in response to the potency of the nitazines, users have developed harm reduction techniques, increasing their uptake of nitazine, trying to inject together, trying to be ready to reverse overdoses. There has been an increase in the utilization of harm reduction services with the take-home naloxone program and more distribution of naloxone at syringe exchange. These increases were starting in 2022. When we interviewed the nitazine users, we found that it's very difficult to be a nitazine user in Estonia now. The drug supply is uncertain. You can't really be certain what you will get when you buy drugs. There could be various adulterants. You don't know exactly what the strength is likely to be. And basically, the person selling you the drugs will not have a great idea of what's in the mixture or the strength, so you can't rely on what the seller may say. As I mentioned, there's short action of drug effect, it's several hours, and then you will be needing another dose. And you get a development of very high tolerance levels and very difficult withdrawal symptoms. Okay. Methadone maintenance is available in Estonia, but the doses of methadone may not be sufficient to avoid withdrawal and may not also fully protect you against withdrawal from if you have a nitazene habit and you're on methadone. A lot of people are developing the high tolerance to where they're no longer getting a euphoric effect from the nitazenes. They're basically just trying to avoid withdrawal, and they don't report any euphoria from continued use. And they report they're tired of the life. They're feeling burned out, that they're chasing drugs, they're getting some drugs. It's very difficult, but they're not getting euphoria. They're basically just sort of trying to maintain so that, you know, we've done these types of qualitative interviews with heroin users in the US and fentanyl users in the US and fentanyl users in Estonia previously, and really the nitazene users appear to be more bummed out by their drug use than either the heroin users or the fentanyl users that we've interviewed. Okay. Nitazenes present very formidable challenges. There was really a delayed awareness of nitazenes. I mentioned the first nitazenes were detected in 2019, and then the great increases in 2023 and 2024. But Estonia still has not really figured out just what to do about nitazenes. There's been clearly the surge in drug-related deaths. There has been more distribution of naloxone, but it still has not brought the death rate down. As I mentioned, there's people are not necessarily aware of what they're using, and the sellers may not be aware of what they're selling. And this has been a considerable strain on emergency healthcare providers and on the police in terms of trying to enforce laws and trying to deal with the overdoses. The emergency services are not really prepared in terms of what to administer for a nitazene overdose. It may take multiple naloxone, and you may need to give multiple doses over time because the nitazene can wear off quickly. We really need improved detection and control measures. There's a need for rapid and accurate identification of these novel psychoactive substances. That if we don't know what we're dealing with, we're probably not going to do a good job of dealing with it. Estonia and the US pretty soon are going to need real-time information of drug trends, and we'll need innovative surveillance methods. Wastewater is a particularly useful method, but we need ways of doing drug testing immediately before or right after people use it. And we need ways of disseminating the information about what drugs are being used, the quality, the purity, the strength, how to deal with overdoses. And we need to train first responders because they're the ones who are going to be dealing with a lot of these drug overdoses. I would suspect that there are very few first responders in the US who have even heard of nitazenes, even though we have detected them occasionally in the US. They're not at a public health emergency level, but they're, according to the US Office of National Drug Control, they're on a watch list for particular development of new problems. And we also really don't know how to treat nitazenes. We don't know, do you just treat this like any other synthetic opioid? Do you try to distinguish between the different nitazenes? What levels, how do you get people with high nitazene tolerance onto either methadone or buprenorphine? How you might get them to detox from nitazene. What are the best ways of trying to deal with nitazene withdrawal? Again, this is sort of a whole new challenge that Estonia is facing right now, and there is the possibility, maybe even the likelihood, that the US and Europe will be dealing with this challenge. In terms of conclusions, the nitazene epidemic in Estonia is a critical reminder of the dynamic nature of drug supplies, that once we learn how to deal with one thing, we should expect a new problem to arise, and we need to have a system that is adaptable to new patterns of drug use rather than fighting the last drug war. The poppy ban in Afghanistan may further the use of novel synthetic opioids. And we need to develop further responses to the potential loss of lives. These new synthetic opiates tend to be much more potent and tend to lead to much higher rates of fatal overdoses. Okay. Nitazenes were legal when they first were seen in Estonia because they were sufficiently new that they had not been outlawed. They were criminalized in 2023, and we're now waiting to see what the effects of that criminalization will be. Will it lead to a potentially worse underground market, or might there be some reduction in supply? Also, there was a recent Chinese restrictions on precursor components in nitazenes, so that may have an effect. Again, the situation is really quite fluid. And nitazenes are to fentanyl as fentanyl was to heroin. They're more potent, they're shorter acting, they tend to replace the drug in the supply. So all of the problems that we had going when fentanyl replaced heroin in the US are likely to be more intense if nitazenes happen to replace fentanyl in the US. And finally, the lives of people using nitazenes are really stressed out, bummed out. There's little joy in being a nitazene user. We need to think in terms of how we might deal with these people to give them their lives back, because on nitazenes, it's very, very difficult to just survive, much less have any sort of fulfilling life. Thank you. Okay, I think, Nick, your hand was first.
Thanks, Don. That was excellent. we've got an interesting situation in Australia where we're actually had a spate of nitazene cases in the last 12, 18 months. So we've actually seen more nitazene cases than we have fentanyl cases in Australia with regards to people then presenting for treatment. We struggled with a lot of those patients, stabilising them with buprenorphine, but really easy using methadone, surprisingly easy. Whereas the buprenorphine, it was just a little bit messy as to how we used it. That was partly our own lack of confidence, whereas with methadone, it was just so simple. Stabilise patients by the second or third day, and they stopped using nitazenes. What we're unfamiliar with, though, and what we can't really get a strong sense from, because we just don't have the case reports, what was the response of using take-home naloxone in individuals experiencing overdoses of nitazene? Like, was it effective? Did they need higher doses? What was the experience?
It varied in part because the responses to naloxone among people with nitazene overdoses varied because in one part of it is that the quality or strength, potency of a nitazene dose may vary tremendously. And with the sailor really not knowing just what the potency is. Naloxone certainly, it can be effective, but you have to be ready to give multiple doses and you have to be ready to stay with the patient for hours in case the naloxone might wear off before the nitazene does. So naloxone still works, but it's just more complicated to use it with these new drugs.
So it's the same messaging as we would normally do with naloxone?
Yeah.
Give it again if you've got it, call the ambulance, wait until they come.
Yeah. And we should be collecting more data on nitazene overdoses. You know, right now, most overdoses, we don't even test to see whether nitazenes are present, so that we haven't developed really a system for collecting data on nitazene overdoses to find out just how effective naloxone is, how long you should babysit the patient and such.
So my question was on the testing. In Estonia, do they regularly test for nitazenes, and are there any quick tests for it?
There aren't quick
No.
yet. They're in development, but they're not the test strip type tests that you can. Okay. Yeah, we don't really have commercially available test strip quick tests for nitazenes yet. I mean, it's certainly feasible, and they may be coming very, very soon. Part of the challenge is that there are a lot of nitazenes, and to get a test strip for all of the different variations may be more difficult.
Thanks, Don. You raised a whole lot of really good questions about the nature of nitazene use disorder and how it's best managed. My understanding is that access to opiate treatment is reasonably good in Estonia, but if you could talk about that. And this would seem an ideal opportunity to gather that clinical information about what's, induction doses, dose escalation, what's different about treating heroin or other opiate dependencies. So are there any plans to do that at the moment?
You're right that Estonia offers a wonderful opportunity to collect good research data. They have very good researchers there. And the NIH policy of doing research in foreign countries is going to make it extremely difficult to get NIH money to do nitazene study. I mean, I've had NIH money to do research in Estonia for about 15 years, but getting the next grant to study research in Estonia is going to be a very big challenge under the new HIV regime.
Thanks, Son. I want to challenge you a little bit, although I fully recognize that it's unlikely there are any data with this challenge. In your conclusion slide, and I think even the title, you talk about nitazenes are to fentanyl as fentanyl was to heroin. But in Estonia, there was a 2-year drought. And so kind of collective community tolerance was lost, and then nitazenes showed up. What would you speculate would have been the effect, or would be the effect in the United States, where there's not an interruption of fentanyl, but suddenly the nitazenes show up? Would there be as serious of an issue?
I think it would be as serious if you add nitazenes to the US supply. But you're right that the change from baseline, when you didn't have fentanyl to nitazenes, is going to be much greater than the change from baseline with fentanyl to a fentanyl plus nitazenes. So I think the nitazenes would still create a bigger problem in the US, but it wouldn't be as big a change from a baseline of no fentanyl.
Hi, Don. Lovely talk, and it's both good to hear you talk about a proper study of the Estonia situation, and then disappointing to hear your comment about the difficulty there'll be in the current climate, because the ability to study outbreaks like Estonia, for its fentanyl outbreak, for its fentanyl problem for 20 years or 15 years before the rest of the world started worrying about it, you think it would pay dividends to have studied it and to know it better. Answering the last question, I mean, the UK and Scotland in particular has had a small, compared with Estonia, there's a current concern about the growing amount of nitazene use, both from contamination of what was thought to be heroin or thought to be other non-opiates as well. And the overdose problems have certainly been seen as considerable with it. So, and there hasn't been a 2-year collective loss of tolerance in the UK. But the testing was the point I was going to ask you a question about. One of the worries I've had about the reports of the appearance of nitazenes in samples seized is our laboratory methods are so incredibly good now that you can detect true micro doses of it. And I guess we're really wanting to know, is this just slightly shoddy, illicit pharmaceutical practice where there's a trace which is of minimal true effect, in which case it's a criticism of the quality control, but that's all? Or is it truly dangerous? And a lot of the inherent dangers of fentanyl, which was, a widely used medicine for 30 years or something, was to do with, you made the point that the errors in dose can be so much greater because you're in micro quantities. And I think we're going to have to push the laboratory testing of it to give us something quantitative about, was this a major effect within the samples seized or just trace amounts which weren't of much importance?
John, I think your point is well taken, that we need to not do just qualitative testing. Is there some amount of X in this sample to move to how much X is there? I mean, because some of the tests are sufficiently sensitive that it might be just that I was mixing up a batch of fentanyl and then I moved on to mixing batches of cocaine and had a little fentanyl on my hands where I made the cocaine, and yet the fentanyl shows up when you test the cocaine, even though it's not at any sort of pharmacologically effective dose. So that if we're going to really do testing to help users in the field, we're probably going to need to do some sort of quantitative testing as well as qualitative testing. Well, okay, as one of the chairs of the session, I'd like to thank all of you for attending and with the good questions you've asked.